All right, let's cut right through all the noise surrounding eating disorders. We're going to focus on the high-yield, must-know clinical facts you need for your exams, and honestly, for being a safe, smart nurse.
So here's the game plan. We're going to visually map out each of these big ones. First up, anorexia and that life-or-death refeeding emergency. Then we'll draw a really clear line between bulimia and binge eating disorder. After that, we'll uncover the anorexia mimic, ARFID, and then break down the more mechanical issues of pica and rumination. And we'll wrap it all up with a clinical decision point to put your knowledge to the test.
All right, let's dive right in. Grab your mental whiteboard, because we're starting with the big one, anorexia nervosa and the super dangerous complication of refeeding.
Okay, so to really get this, I want you to picture drawing a house stuck in a blizzard. This house, that's the body in starvation mode. It's doing everything it can just to survive, right? So it starts shutting down everything that's not absolutely essential. The thermostat, it drops. That's your hypothermia. The electricity dims way down. That's bradycardia. And then, to try and trap every last bit of heat, the body grows this super fine downy hair. We call that lanigo. It's like a fuzzy blanket. This picture right here, this is the core physiology of starvation.
So when you walk into that room, your assessment has to immediately lock onto three things. We call it the anorexia triad, and you can't miss it. First, a BMI under 18.5. That's a hard line in the sand. Second, check those vitals. They're going to be slow. Bradycardia, hypotension. And third, that physical exam finding, lanugo, that fine body hair. These are your big objective red flags.
Now, this is so important for your communication. You absolutely cannot argue with a cognitive distortion. Telling a patient you're too thin is like yelling at your reflection in a funhouse mirror. It's just not going to work. The therapeutic way is to sidestep that distorted thought completely and go for the feeling behind it. Our job isn't to fix their reality. It's to help them talk about how they feel about it. Okay, huge red flag here. Let's go back to our freezing house. Imagine it's been freezing for months, and you suddenly blast the furnace on high. What happens? You don't just get heat, you blow the circuits. That's refeeding syndrome. The sudden rush of nutrition causes these massive, life-threatening electrolyte shifts. This is a full-blown medical emergency.
And you got to burn this into your brain. The only way to treat refeeding syndrome is to prevent it in the first place. There's no magic pill once it starts. The standard of care is start low and go slow. A really measured reintroduction of food and fluids with constant cardiac and electrolyte monitoring. We have to catch those shifts before they turn into a catastrophe.
Okay, professor's trap alert. This is a classic NCLEX style question. You get a client with a BMI of 17.0. They're binging and purging. So naturally, you're thinking bulimia, right? But is that the correct diagnosis?
And the answer is a hard no. This is where the diagnostic hierarchy is king. If that BMI is under 18.5, the diagnosis is always anorexia nervosa. In this case, it's the binge eating/purging type. Remember, the dangerously low weight always trumps the behavior.
Okay, so now that we've hammered home how important weight is for an anorexia diagnosis, let's shift gears. We're going to look at two disorders where weight can actually be a bit of a red herring: bulimia versus binge eating disorder.
Let's draw another map for this one. Think of binging like racking up a crazy amount of credit card debt. With binge eating disorder, that debt just piles up, which leads to weight gain. But with bulimia, the person racks up all that debt and then immediately tries to erase it using some kind of destructive method, like purging. That right there, that's the single most important difference you have to know. Is there a compensatory behavior or not?
So, it all comes down to what happens after the binge. People with bulimia nervosa use those compensatory behaviors we talked about: purging, excessive exercise, fasting. And here's the tricky part. This often means their weight is in the normal or even overweight range, which makes it super hard to spot just by looking at them. On the other hand, with binge eating disorder, you don't have those compensatory behaviors, so the weight gain is usually more apparent.
So, since weight isn't always a giveaway for bulimia, you have to play detective and look for the physical evidence of purging. There are three classic signs you got to recognize. Number 1, Russell's sign, calluses on the knuckles from inducing vomiting. 2, dental erosions from all that stomach acid. And 3, swollen salivary glands, what we call parotoid hypertrophy. Okay, listen up. If your client with bulimia ever says they're having palpitations, your internal alarm bells need to be screaming. This is not a "we'll check on it later" symptom. It's a huge sign of a potentially lethal electrolyte imbalance, specifically low potassium from purging. This is your warning shot for cardiac emergency.
So what do? Your absolute #1 priority is to assess the heart. Get an EKG stat. You're looking for signs of hypokalemia, specifically that prolonged QT interval. That's a major precursor to deadly arrhythmias. Cardiac arrest is a top cause of death in bulimia, and that EKG is your first and best line of defense.
All right, let's move on to a trickier diagnosis, one we call ARFID. That stands for Avoidant/Restrictive Food Intake Disorder. Now, this one can look almost identical to anorexia on the surface, but the why behind it is completely different.
Let's sketch this out. With anorexia, remember, the path to eating is blocked by that distorted mirror, that body image issue. With ARFID, there is no mirror. Instead, the bridge to actually eating is broken because of faulty alarm systems in the brain. The brain is literally flagging the food itself as dangerous. Maybe it's a sensory thing, maybe it's linked to a past trauma like choking, or maybe there's just no appetite signal at all.
So your job as the nurse is to figure out which of these 3 things is driving the restriction. Is it an extreme sensory sensitivity to textures or smells? Is it just a profound lack of interest or hunger cues? Or is it a true phobia, an avoidance linked to a past trauma? Because how you intervene depends entirely on which of those paths the patient is on.
Okay, let's wrap up with 2 last disorders that are, a little different. They're less about the psychology of body image and more about a mechanical breakdown in the whole process of eating. We're talking about pica and rumination disorder.
And the best way to picture this is with a conveyor belt. Normal eating is a one-way belt, right? Food goes in, goes down. Well, with pica, the person is putting the wrong things on the belt. Non-food, sometimes dangerous items. It's an input problem. With rumination, the food goes on the belt and goes down, but then the belt just runs in reverse, bringing the food back up effortlessly. That's a processing problem.
And knowing that mechanical difference is so crucial for how you talk to these patients. You would never tell a client with rumination to stop vomiting, because it's not vomiting, it's an effortless regurgitation. Saying the wrong thing isn't just inaccurate, it can be really shaming. Now for pica, the strategy is all about redirection. You don't punish the behavior, you gently redirect that impulse to something safe. So, hey, let's choose these carrots instead of the Play-Doh.
Okay, time to put it all together. We've covered a lot of ground, so let's synthesize everything we've talked about with a single, high-stakes clinical decision point.
Okay, you're the nurse. You just got this report from the ER. You have a 16-year-old coming up. BMI is 16.8. She's bradycardic, and you see she has calluses on her knuckles. She even tells you, I have to vomit after I eat big meals or I'll get fat. So take a second, look at all that data. You've got clear signs of starvation and clear signs of purging.
So here it is, the big question. Based on everything you see, what is your absolute #1 priority action? What do you do first? This is where you have to weigh multiple competing life-threatening risks. You have to figure out the right diagnosis first, and then decide which immediate threat is going to harm your patient the fastest. What's your first move? Because in this situation, it could make all the difference.